Good morning, everyone. So today I would like to take this opportunity to welcome you all to this MHG webinar that is organized on the topic of chronic myeloid leukemia, challenges in clinical practices. And I would like to start. Sir, can you help me if the slides are moving? Can you confirm?
Double click the, you need to double click it, then the slides will move.
Yeah.
Recording in progress.
Yes, we can see now.
Yeah. So I would like to continue in this build-up and would like to start this session by thanking Professor Dr. M.B. Agarwal, under whose guidance and assistance we are organizing these MHG webinars. And talking about our today's moderator. Talking about our today's moderator, Dr. Amit Khurana, and we all know him well. And Dr. Amit Khurana is a highly skilled and experienced hemato-oncologist with a decade of experience in this field. And he has a fellowship in bone marrow transplant, hematology, clinical hematology, and is an expert in managing these hematological and hemato-oncologist patients. And he's also experienced in performing bone marrow aspiration, bone marrow biopsy, and other hematological procedures. And he has an extensive experience in both autologous and allogenic stem cells transplants. For our today's speaker, Dr. Malini Garg, I think Dr. Amit Khurana will be doing a better job than me than introducing her. So, sir, I would request you to take this forward and introduce our today's guest speaker.
Thank you, Vastavita.
Yes, sir.
Let me share the screen.
Yeah.
You will unshare your screen first. Yeah. Thank you. Well, very good morning to all of you, and good afternoon and good evening to all of those who are joining from the rest part of the world. Today, our guest speaker for the day is Dr. Malini Garg from Gwalior, and she's going to lecture us on chronic myeloid leukemia, challenges in clinical practice. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and team INTAS, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Anshul Gupta from Lucknow, our guest speaker for the day, Dr. Malini Garg from Gwalior. All our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for spending a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 14th of September 2024, from 7 p.m. Indian Standard Time and 8:30 a.m. US Central Time, your Dr. Nitin Jain from Houston, Texas, USA, speaking to us on CLL in 2024, What's the Unmet Medical Need? And the following day, that is Sunday, 15th of September 2024, from 11:30 a.m. IST, Indian Standard Time, and 7 a.m. UK time, your Dr. Shankara Panisha from Birmingham, UK, speaking to us on how do I manage indolent lymphomas in 2024. Let me introduce our discussions for the day, and here displayed in alphabetical order. To start with, we have Dr. Abha Dubey from Arvita Super Specialty Clinic, Ahmedabad. Dr. Akanksha Garg from Zydus Hospitals and Zydus Cancer Center, Ahmedabad. Dr. Akshay Mandloy from Agilus Diagnostics Mumbai Reference Lab, Mumbai. Dr. Anil Sharma from Cancer Hospital and Research Institute, Gwalior. Dr. Surgeon Commander Dr. Arun V.A. from INHS Aswini Kolaba, Mumbai. Colonel Dr. Ashok Meshram from Command Hospital, Kolkata. Dr. Asraful Haq Chaudhary from Dhaka Medical College Hospital, Dhaka, Bangladesh. Dr. Deepak Charles from Aster MedCity, Kochi. Dr. Deepika Gupta from Sri Mata Vaishno Devi Narayana Super Specialty Hospital, Katra, Jammu. Dr. Geeta Vidyadharan from Karkinos Laboratory, Kochi. Dr. Gopinathan M. from MGM Healthcare, Chennai. Dr. Neemya Thanda from North Okkalappa General Hospital, Myanmar. Dr. Kunal Goyal from Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai. Dr. Mallikarjun Kalashetty from Comprehensive Cancer Center, Manipal Hospital, Bangalore. Dr. Mohammad Taha Ali Khan from Medicover Hospital, Hyderabad. Dr. Mona Vijayaran from SGPJ, Lucknow. Dr. Muhammad Rifai from Government Medical College, Calicut, Kerala. Dr. Nailesh R. Shah from NHL Municipal Medical College, Ellisburg, Ahmedabad. Dr. Navid Tamboli from MGM Hospital, Vashi. Dr. Nikhil Kumar from Fortis Memorial Research Institute, Gurugram. Dr. Prantal Chakrabarti from NRS Medical College, Kolkata. Dr. Radhika KK from Nizam's Institute of Medical Sciences, Hyderabad. Dr. Rajni Priya Yedla from Mahatma Gandhi Cancer Hospital and Research Institute, Vishakhapatnam. Dr. Rajkumar Ramaswamy from Velamur Specialty Hospital, Madurai. Dr. Sandeep Bartake from Bharati Vidyapit Medical College, Pune. Dr. Satish Kumar A from Manipal Hospital, Yashwantpur, Bengaluru. Dr. Savitri Singh from Postgraduate Institute of Child Health, Noida. Dr. Shriram Kane from Dr. Kane Hospital, Nagpur. Dr. Sukriti Gupta from Artemis Hospital, Gurugram. Dr. Umang Patel from Green Cross Genetics Lab, Ahmedabad. Now is the time to introduce our special guest and chief guest for the day. We have with us Dr. Anshul Gupta from Lucknow. Dr. Anshul Gupta presently works as Director at Department of Hemato-Oncology and Bone Marrow Transplant at Medanta Hospital, Lucknow. He formerly worked as Additional Professor at Department of Hematology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, Uttar Pradesh from the year 2013 to 2022. He holds the credit for establishing the first dedicated pediatric bone marrow transplant center at Navalokka Hospital, Colombo, Sri Lanka from the year 2012 to 2013. He graduated from Jawaharlal Nehru Medical College, Aligarh, Muslim University, Aligarh in 2004. He underwent postgraduate training in pediatrics with gold medal from Jawaharlal Medical College, Aligarh, Muslim University, Aligarh, Uttar Pradesh in 2007. Followed by, he underwent 3 years FNB training in pediatric hemato-oncology from Rajiv Gandhi Cancer Institute Research Center, New Delhi. He also conferred gold medal by National Board of Examination in the fellowship exit exam. He worked as fellow trainee for 2 years in Department of Hemato-Oncology and Bone Marrow Transplant at Rajiv Gandhi Cancer Institute, New Delhi. He underwent observership in pediatric bone marrow transplant program at St. Jude's Children's Hospital, Memphis, USA. His special interest in pediatric leukemias, hemoglobinopathies, bleeding disorders, and stem cell transplant. He has been the principal investigator for several extramural research projects on thalassemia and hemophilia and holds the credit for establishing Center for Excellence for Hemoglobinopathies and Bleeding Disorders at Department of Hematology, SGPJ, Lucknow. He has more than 80 publications in several national and international journals. It's my privilege to welcome Dr. Anshul Gupta to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Anshul Gupta.
So, good afternoon, everyone. And it's my pleasure. First, I would like to thank Professor M.B. Agrawal and the Mumbai Hematology Group for inviting me as the guest, chief guest for this session. And I should really appreciate the efforts for last 3 years the MHG Group is putting in to update us in the field of hematology. And these webinars on a regular basis are being organized by the MHG Group. And without any failure, even during the COVID times, they have been constantly doing these webinars. And I should really appreciate the consistency with which the MHG is hosting these webinars. And today, we have a very eminent speaker, Dr. Malini, and she would be speaking on chronic myeloid leukemia and the challenges which we face in our day-to-day practice in its management. We all know that chronic myeloid leukemia is one of the success stories in the field of hematology because this was the first disease where the targeted therapy was implemented in the form of imatinib, a tyrosine kinase inhibitor, way back in 2000. And at that time, it was considered as a magic bullet for the disease which was incurable earlier, had become completely curable with just patient having to take only a single pill. And with that, it ushered the era of targeted therapy in oncology. Many more drugs came in hematology, many more drugs came in oncology. But definitely, CML holds a special place in whosoever hematologist who is practicing hematology or malignant hemato-oncology, that this is the one disease which every hematologist is managing at his or her own place. So, without any further ado, I would like to invite Dr. Malini. She is a senior consultant. Can I have her CV slide, please?
Uh, sure, I'm going to introduce her, Dr. Anshul.
Okay.
Yeah.
So, with this further ado, I would request Dr. Amit Khurana to kindly introduce our eminent speaker. Thank you.
Thank you, Dr. Anshul Gupta, for the great words of wisdom. And thank you for accepting our invitation as our chief guest for the day. Thanks a lot. So now it's a time to introduce our guest speaker for the day. We have with us Dr. Malini Garg from Gwalior. Dr. Malini Garg is DNB, DM in clinical hematology, hematologist, hemato-oncologist, and BMT physician at BIMR Hospitals, Gwalior, co-director of Gwalior Hematology Center, Gwalior. Dr. Malini completed her MBBS from Mandya Institute of Medical Sciences, Karnataka in 2007. After that, she did her post-graduation from NDMC Medical College and Hindurao Hospital, Delhi. She pursued DM in clinical hematology from NRS Medical College and Hospital, Kolkata from August 2018 to August 2021 and received the gold medal for highest marks in university examination for DM clinical hematology. She worked as specialist registrar in bone marrow transplant unit at ACTRAC, Tata Memorial Hospital, Kharghar from October 2021 to October 2022. She also gained experience in managing CAR T-cell therapy patients at ACTRAC during that tenure. She was actively involved in various research projects in hematopoietic stem cell transplant during her training at ACTRAC, Navi Mumbai. After that, she worked as assistant professor in adult hematolymphoid and bone marrow transplant unit at HBCH Varanasi, a unit of TMC from November 2022 to December 2023, and was a part of various research projects and trials. She was actively involved in teaching of DM students as well. She's currently working as consultant hematologist at BIMR Hospitals and co-director of Gwalior Hematology Center, Gwalior, and working towards establishing standard hematology practices in the city. She has multiple publications and has presented both oral papers and posters in various national and international platforms. She has contributed to a chapter on approach to a case of polycythemia, More Blood May Be Bad in Medicine, Update 2021, and a chapter on diagnosis and management of high-grade NHL in ICP-ICH monogram on advances in hemato-oncology. She has special interest in bone marrow transplant, including both autologous and allogeneic stem cell transplant, acute leukemia, especially AML, multiple myeloma, and CML. And today she's with us, and she's going to lecture us on chronic myeloid leukemia challenges in clinical practice. Well, thank you so much. I stop over here. Over to you, Dr. Malini Garg.
Thank you, sir. Good morning, everyone. Thank you so much for the kind introduction. And thank you. Are my slides visible?
Yes. Can you please put in full screen mode?
Yes. Are they visible in full screen mode?
Perfect. Perfect.
So before starting the today's lecture, I would like to thank MB Agarwal, sir, for giving me the opportunity to present at this platform. And so without delay, we'll be starting the lecture. And thank you, everyone. So good morning. So today we'll be discussing about chronic myeloid leukemia challenges in clinical practice. See, this I'll be discussing this in 4 headings, basically. First, selecting a frontline TKI therapy, what to choose, and how to monitor treatment response, whether to switch or not. TKI resistance or intolerance, what is it actually, and whether to discontinue or not. So it is very important because these are the points which we discuss, face day to day. CML is a kind of disease when everyone of us, whether we are practicing at a ground level or at higher centers, all of us, we see CML patients. So I'll be focusing especially on resource poor settings and real world settings. So to start with, we know what is chronic myeloid leukemia. It is a myeloproliferative neoplasm characterized by balanced translocation between BCR and ABL, resulting in a Philadelphia chromosome, resulting in a fusion oncoprotein that translates into an oncoprotein and which causes constitutive myeloproliferation. Why we need to know about CML? Because this is a kind of disease which has a very good survival rate after introduction of imatinib. The 10 years CML survival rate is 90%, and mortality is only 10%. The 10-year rate of CML resistance is 10%, and the 10-year incidence of blastic transformation after frontline therapy is 5 to 6%. Still, in we see in our clinical practice, there are around 5 to 10% of CML cases which differ from this and actually pose a very much clinical challenge that what to do with those particular cases, and they result in treatment failures. So as a clinical cause of disease progression, if remain untreated, CML progresses from a chronic phase to accelerated phase to blast phase, as we all know. The recent WHO classification, however, has redefined the CML risk factors, and accelerated phase is no longer required. They have omitted the current classification, accelerated phase from the current classification in favor on an emphasis on high risk features, which are associated with CP progression and resistance to TKI. According to them, the criteria for blast phase includes more than 20% myeloid blasts, or presence of extramedullary proliferation of blasts, or presence of increased lymphoblasts in peripheral blood on bone marrow. And the cutoff for the lymphoblast is actually not defined. It is unclear. And why they have put this stage? Just because with the advent of TKI therapy and monitoring, the incidence of progression to advanced phase has gradually significantly decreased, and the 10-year survival rate of CML is 80 to 90%. So, where the resistance of TKD mutations is there, additional cytogenetic abnormalities and development of BP represents the key disease attributes, the designation of AP has actually become less relevant. So without wasting time, with a basic introduction, we'll go ahead to discuss the clinical challenges. So to start with, I'll just try to discuss a simple case scenario to see what are the challenges we face. So basically, a patient, Mrs. A, she presented to our emergency room with a history of pain abdomen and with massive splenomegaly. Peripheral smear examination was suggestive of MPN. So basic investigation of bone marrow studies was said. So the first question that always struck us is what the investigations are to be done at the baseline. We all know after the physical examination and complete blood count and microscopic differential suggested a case of MPN, we have to go ahead with bone marrow aspirate and biopsy along with cytogenetics. Biopsy is required to look at fibrosis and the degree of the number of blasts, basically, which can be missed on aspirate, and cytogenetics to look for additional chromosomal abnormalities. We have to look at qualitative RT-PCR for the transcript type, and in pH negative cases, we can go ahead with FISH also. And then we have to do some routine investigations for the starting of treatment. So our case was confirmed as CML CP with SOCAL index of 1.1 intermediate score. So the next question that comes in mind is how to choose the frontline CML therapy. We have a whole basket of CML TKI drugs available to it. So to start and choose a frontline CML CP therapy, 4 considerations have to be kept in mind. First, what is the aim of therapy? Second, what is the CML risk profile? Third, what is the patient age and comorbidities? Fourth, when we are dealing with the real world scenario and resource poor settings, we also have to look at the pocket of the patient. So cost and affordability of the TKI under consideration is very, very important. So to start with, what is the appropriate goal of CML therapy? We know that there are just 3 main goals. Whether the patient requires normalization of survival, which is relevant for older patients. The second one, possibility of the achievement of durable DMR, which can translate into a treatment-free survival, treatment-free remission status, which is relevant more for younger patients. So first, when we have seen a patient and we have put in our mind what is the goal of the CML therapy in this particular patient, secondly, we have to determine what is the risk status of this patient we are thinking of starting a TKI therapy. So from the era of 1985, we have various risk scores being followed. Initially, it was SOCAL, then came Euro, then UTOS. At present, we are following UTOS long-term survival score. So this is a picture which shows how to calculate these scores. So along with the ELTS score, what all extra we have to look at determining the prognosis? whether the patient has some major root cytogenetic aberrations or chromosomal free aberrations or bone marrow fibrosis at diagnosis. And any one of these characters are present in our mind that makes a patient as high risk, and if patient becomes unfavorable, has unfavorable outcome after imatinib therapy. So these are the two considerations. First was the aim. Second, we have determined the risk status of the patient. So after we have done that, we then think how many drugs are available to us. So we know that the history of CML is long and the kinase inhibitor era is short. It was first described in 1845, and over the years till 2024, we have a number of treatment drugs available with us. So this figure is showing the evolution of therapy of CML. Till date, we have drugs like asciminib also available to us. So first, in 2001, FDA approved imatinib, after which actually it was a magic bullet which changed the scenario of cancer treatment. So from a disease which was incurable with a survival rate of only 20% became a curable disease with a survival of 80 to 90%. And in today's era, and so we can see the 10-year survival was significantly improved. In that German CML group study, we can see. So initially it was just 11%, but with the advent of imatinib, it became 84%. But in today's era, along with imatinib, we have a number of other TKIs also, like second generation and third generation TKIs are available with us, and we have a basket of TKIs. Now the question arises, what to choose, which therapy should be started for these CML patients as a frontline. We have a whole basket of TKI first liners which have been approved by FDA and EMA both. So this dasatinib, nilotinib, bosutinib, which are the second generation TKIs, they have been tested against imatinib. We all know that, and they have never been tested against each other. There have been various trials. IRIS trial was for imatinib alone, and then we had an ESTEN trial which had tested nilotinib versus imatinib, then DESICIAN trial, then bosutinib for before trial, and BELLA trial. So we all know that this has been known since 2020 that all these trials, what they have shown is the second generation TKIs, the rate to achieve deeper molecular responses is definitely faster with second generation TKIs like dasatinib versus imatinib or nilotinib or bosutinib versus imatinib, but there is no difference in overall survival, and for that matter, for progression-free survival also. Similar is shown in this figure also, where we can see the molecular responses between dasatinib versus imatinib or nilotinib versus imatinib or bosutinib versus imatinib. In all these figures, we will see the rate of achievement of MMR or for that matter DMR is faster with second generation TKI in comparison to imatinib. But the overall survival was definitely same. And when this molecular responses rates were compared in the basis of low risk, intermediate risk, or high risk, there also we saw the difference was maintained. The patients, irrespective of the risk status, when they were started on second generation TKI, they achieved molecular responses faster compared to first generation TKI, that is imatinib. However, there was a difference in rate of progression. So in ESTEN trial, what was seen was the patients who were on low risk and intermediate risk, the low risk, the rate of progression between imatinib and second generation nilotinib was not much difference. But when it came to intermediate risk and especially high risk, the rate of progression between imatinib and nilotinib was significantly different. So the rate of progression to AP and accelerated phase and blast crisis was higher with imatinib compared to nilotinib. However, there was no difference again in overall survival. So the data on second generation TKI, which summarize what it shows, that with second generation TKI, responses are definitely deeper and faster. The progression events to accelerated phase or blast phases are fewer. There are fewer mutation conferring TKI resistance and achieve responses allowing TFR considerations more rapidly. The third thing when we were seeing about choosing a TKI therapy, after knowing a background knowledge of these TKIs is, we look at the patient age, comorbidities, and TKI toxicity profile. So we know that when the patients are younger than 50 to 60 years of age, are expected to live more than 30 years. Basically a Western scenario. For us, it is 70 years to 75 years only is the life expectancy at present. So inducing a durable DMR, which is the aim of the therapy, because that can lead to therapy discontinuation. And we all know that second generation TKIs induce faster DMRs compared to imatinib. So this scenario is particularly useful for younger patients. But for older patients, issue of durable DMR and potential therapy discontinuation plays a less important role. So that was about the age. Then we have to look at the patient comorbidities. So the second generation TKIs have lost a lot of, we can say, side effects, and they are contraindicated in many of our patients. And the patients who are old age, they have a lot of comorbidities. Like this is a figure in which the red shows a warning signal, that these drugs should not be used with such particular comorbidity, like nilotinib. It should not be used in patient who has prolonged QT interval of congestive cardiac failure. Similarly, dasatinib should not be used in patient who has pulmonary hypertension. The orange one indicates intermediate risk of exacerbation of pre-existing conditions. So they should be avoided in like nilotinib should be avoided in hypertension, ischemic heart disease, cerebrovascular thrombosis, or peripheral arterial occlusive disorders, or diabetes mellitus, pancreatitis, or abnormal liver function test. In that case, the safest is bosutinib and imatinib. Still, bosutinib should be avoided in abnormal liver function, and low risk of exacerbation of GI bleeding is also seen in that case. So we have to keep this chart in mind while selecting TKI as frontline therapy for our patients. So again, if we look at this chart, which shows if a patient has particular comorbidities, which is the preferred drug, which is the less preferred drug. So for diabetes, the less preferred is nilotinib. For pulmonary arterial hypertension, the less preferred is dasatinib. For GI issues, imatinib, bosutinib should be avoided. For cardiovascular disorders, nilotinib, dasatinib should be avoided. For peripheral arterial disease, nilotinib, liver, bosutinib, and for renal, imatinib, bosutinib, all these drugs should be basically avoided. A basic word, these trials, what we have seen were of the full dose trials. So just basic word on low dose dasatinib before we go on to the next section. So a trial between 50 mg and 100 mg dasatinib has shown that 50 mg dasatinib has a better molecular response rate at 3 months and 6 months compared to 100 mg dasatinib and imatinib. Also, the complete cytogenetic response rates were better compared to 100 mg dasatinib and imatinib at 6 months, 9 months, and 12 months. Also, we see that the major molecular response rates over time were better in 50 mg dasatinib compared to 100 mg dasatinib and imatinib. So this is also the figure which show that the response rates of 50 mg dasatinib were very good. So the safety profile of low dose dasatinib actually is excellent. And so why this, what is the advantage of this low dose dasatinib? That because of the very good safety profile, less myelosuppression, bleeding, pleural effusion of pulmonary hypertension, the compliance is very, very good. This allows uninterrupted use, resulting in superior efficacy. Then there is a recent study by DEVLEC phase 2 study from Japan, in which they have seen that dasatinib 20 mg daily as frontline CML therapy patients in patients more than 70 years of age has shown good results. The MMR rate at 12 months was 60%, and MRD molecular response, if we see, was around 40%. And the side effects was also low. So in this DEVLEC study, as shown in this figure, we can see the BCR-ABL of less than 10% was achieved in almost around 80% of the patients, and complete cytogenetic response by 12 months was similarly achieved on approximately 80% of these patients. So this study showed that 20 mg dasatinib is safe and feasible among older patients, often with medical comorbidities, allowing the achievement of molecular remissions with lower incidence of adverse effects compared to higher doses. Secondly, coming on to a word of caution for nilotinib for frontline therapy. 10-year cumulative incidence of arteriocclusive disorder events in NSTIN trial has been shown to be approximately 33.4% with nilotinib 400 mg BD. Consequently, this dose should not be used as frontline therapy, although this can be used in later line therapies. Also, the adverse effects of nilotinib are very common, like we have self-limited direct bilirubin, elevation of blood sugar levels, chances of pancreatitis are also there. So they have proposed that nilotinib can be de-escalated safely from 300-400 BD to 150-200 BD to even 200 mg if the patient is having some side effects and considering that the safety concern in these patients who have responded optimally without compromising their efficacy. Next, a word on caution from bosutinib, because bosutinib is prone to cause self-limited gastrointestinal toxicities. The CML experts are actually proposing that when we start or choose bosutinib as a frontline therapy, a thing of strategy of dose escalation should be used. So it can be started as 100 mg daily for 1 to 2 weeks, followed by 300 mg daily for 2 to 4 weeks, and look for the GI toxicity, and then can gradually be increased to 400 mg daily. So what we have discussed far till now is the aim of the therapy, the risk status, patient age, and comorbidities while choosing their TKI and their toxicities. But the most important thing or the issue at present to choose a TKI therapy in real world settings is cost versus efficacy. So with the advent of generics, dasatinib, nilotinib, bosutinib, cost has actually reduced too much. So if we sit in our practice, I see that every other company is now manufacturing dasatinib. But as long as these generic drugs, they meet the national standards of the country involved in terms of quality of production, bioavailability, and efficacy, then it is an acceptable, it is acceptable to use these generics. But we should be very cautious and be very vigilant with generic drugs when changing brands for first 6 months in terms of response and appearance of new side effects. Because if we see many generics recently are coming without any quality checks, or we can say without any studies or background studies in the background, and so we should be very much vigilant while using those generics for our patients. So the cost of 1 month therapy, as we see, if we consider and compare between the patent drug and generics, generics are definitely very less costly. They are the ones which are meeting the bioavailability with the patent drug. They are equally efficacious. So looking at this chart, and then we can look at the patient's pocket, that also makes a consideration, and we can decide the initial therapy for these patients. So what the guidelines say, ELN 2020 recommends that we should use imatinib only frontline setting, and there are only some caveats or some situations where second generation TKI should be used, and which includes younger patients with lower intermediate risk disease, and patients for whom TFR is a higher priority, and women who wish to become pregnant. Thus, imatinib is still the gold standard for newly diagnosed cases of CML-CP in most of the cases. But however, when we choose, it's a summary. We have to look at these conditions and then decide on our TKI therapy. So if the life expectancy is the goal, which is not impacted by CML, choose imatinib. To overcome the high risk CML, choose second generation TKI. If goal is TFR, choose second generation TKI. Limit impact of TKI therapy on comorbidity outcomes, choose imatinib. Quality of life, minimizing adverse effects, choose imatinib. Then the goal is family planning, choose second generation TKI. And when the cost is an issue, choose imatinib. So if the goal is survival, imatinib. If the goal is TFR, second gen TKI. Also, regardless of which scoring system is used, we have to keep in mind that high score is associated with high risk of progression to accelerated phase and blast crisis. Thus, hitting high risk CML hard upfront with the second generation TKI is appealing in patients with high risk disease. So, high clinical risk scores, high risk chromosomal aberrations, C190, second generation TKIs are preferred upfront. There are 16 randomized trials which have shown equivalence of imatinib and second generation TKIs, but this equivalence is when the patients can afford the treatment, they are treated optimally, they are treatment compliant. Treatment is changed from imatinib to second generation TKI promptly whenever there is a need to switch the TKI. However, if the aim, as I have told before, is durable DMR or TFR, then directly we should go for second generation TKI. So if we come back to our case, which I was discussing earlier, which was a case of CML-CP with intermediate risk, with no comorbidities, definitely we chose imatinib for this patient. Now therapy has been started. Now the question arises how to monitor the response. So ELN 2020 has told how to monitor the response is a basic. We initially start with CBC with DLC every 2 weekly, and then we have to document the CHR. And it is recommended that qPCR monitoring should be done every 3 months. But in a clinical scenario, initially we are doing it at 3 months, followed by 6 and then 12 months. And cytogenetics alone is not sufficient. It should be done for atypical BCR-ABL1 transcripts. We know about the response definition and monitoring. I'm not going in detail. The definition of hematological responses, cytogenetic responses, and molecular responses. So we know these molecular response definitions. I'm just telling because we'll be using this term again and again. So complete cytogenetic remission is where the BCR-ABL1 transcripts are less than or equivalent to 1%. Major molecular response when it is less than or equal to 0.1%. And beyond that, everything is deep molecular response. So why it is important to know the monitoring? Because these BCR-ABL transcripts at particular time points determine whether the response is optimal, bonding, or failure. Now, ELN and NCNCN networks, they have given some cutoff points. But the question arises, are these cutoff points really relevant in our real world settings? Or they can be a little bit deviated also from. So we know these charts, which was published in ELN 2020, and we are using it day to day that what is optimal time points, what is bonding time points, and what is defined as failure time points. So if the patient has optimal response, we know we continue the therapy. If the patient has failure, we change the therapy. And in bonding, we continue or change depending upon characteristics, comorbidities, and tolerance. Important thing that ELN has recommended that a change of therapy may be considered if MMR is not achieved at 36 to 48 months. But I'll be discussing in later that is it really relevant in the real clinical settings that do we need to change the therapy or not? That is still a question. And another thing they recommend is additional qPCR testing may be done if kinetics are not clear or if toxicity or intolerance causes dose interruptions or reduction. So ELN recommendations and NCCN guidelines, they have suggested and updated their clinical treatment milestones that define warning signals and failure resistant signals. The early MR milestones are that BCR-ABL1 transcript should be less than 10% at 3 and 6 months. And they for later molecular milestones, they are seeing that consider MR2 at 12 plus months or MMR at 36 to 48 months. If these are not achieved, therapy should be changed. However, these milestones have actually confused the community practice into changing TKs often and actually unnecessary. So what are the considerations which most of the CML experts are talking about? So what they say, that changing a TKI before or around 3 month landmark is actually unwarranted, unless there is a clear-cut evidence that there is CML hematological resistant and not just BCR-ABL1 transcripts are more than 10%. So according to them, at 3 months, if the BCR-ABL transcripts are 11%, 12%, and there is no other criteria or evidence of CML hematological resistance, TKI should not be changed unnecessarily. However, at 6 months, if BCR-ABL1 is more than 10% and imatinib was the drug to be started, then a consideration for second generation TKI can be taken. But if the patient was on second generation TKI to start with, and BCR-ABL levels are at 6 months or more than 10%, then directly we should not jump to a third generation TKI or LOHSCT. And all these data they are saying because the overall survival is actually more or less similar in these patients. And but changing to a third generation TKI or directly considering to LOHSCT adds to the morbidity for the patient. These are the various considerations by the various CML experts worldwide. Also, they say that Also, they say that the resistance is defined as when BCR-ABL1 is more than 1% at 12 months or later. And that is a clear indication of CML resistance and the need to change the TKI therapy. They also say that TKI should not be changed unnecessarily just to deepen the MR. Suppose a patient is in MR2 and just we want to deepen the MR and we change the TKI. No, this should not be done because it causes more harm than better. New toxicities, increased cost, and actually confusion. And also in a particular case of older patients, the persistent BCR-ABL transcripts of 1 to 10% at 2 years or later in patients who have actually exhausted all the possible safe TKI permutations, they may not warrant a consideration for LOHSCT, because it has been seen that if these patients, they remain even in chronic phase without a complete cytogenetic response, they have a very good overall survival of approximately 10 years from daily optimal TKI-based therapy combined with hydroxyurea, cytarabine, hypomethylating agents, or omecectazine. So what considerations have to be done while monitoring? So if the patients are in complete cytogenetic response, just the achievement and maintenance of DMR is of debatable significance for survival, unless the treatment aim is durable DMR or TFR. Why? Because the patients in complete cytogenetic response have similar survival regardless of whether or not they achieve a MMR or DMR or not. So, though complete cytogenetic response achievement is the primary endpoint of TKI therapy in our practice, in several studies, it has been seen that achievement of complete cytogenetic response at 12 months or later on TKI therapy were associated with significant survival benefit compared with achievement of less degree of response. However, when it was compared with more degree of response, achievement of MMR is associated with modest improvement in event-free survival, but survival benefit is actually similar whether to achieve complete cytogenetic response or MMR. So durable DMR offers the possibility of treatment discontinuation in TFR, but lack of achievement of MMR or DMR should not be interpreted as just a need to change the TKI therapy or just to consider the patient for LOHSC. These are the considerations with the patient, with the CML experts worldwide are actually proposing these days. So when we come back to our case, so our patient who was a case of CML-CP, intermediate risk, started on imatinib, attained CHR at 3 months with RQ-PCR of 8%, and at 6 months RQ-PCR was 0.65%. However, at 8 months started developing pancytopenia. So cytopenias following TKI therapy is one of the most common complications we see in our day-to-day practice. So we just stopped imatinib and folic acid was started, and we waited for the recovery. Counts actually did not recover, and counts started going down. So what next? How to go ahead? So before going ahead, I will tell about what is TKI intolerance and what is resistance. So ours was a case of actually TKI intolerance. So what is TKI intolerance? TKI intolerance is basically some adverse effects the patients which are getting, which can be managed just by reducing the dose rather than changing the TKI. So like cramps and myalgia, fluid retention, impatient nausea, diarrhea, pancreatitis, like rash, neutropenia, thrombocytopenia, raised creatinine. These all are, when they are due to TKI intolerance, they can be managed safely today with dose reductions of the same TKI rather than changing the TKIs. So the difference between intolerance and resistance is we have to look at the molecular response to decide whether patient is resistant or not. If there is no hematological response at 3 to 6 months, no molecular response at 6 months, no cytogenetic response at 6 months, major cytogenetic response at 12 months, or complete cytogenetic response at 18 months, then we label them as primary resistance, which occurs in approximately 10% of patients after 10 years of treatment. And the secondary resistance is loss of response in patients previously responding. The most common cause of resistance is BCR-ABL1 kinase domain mutations. So just before defining a patient that is having TKI resistance and modifying the therapy, again, treatment compliance and drug interactions are very much important. Adherence has to be seen before labeling the patient as TKI resistance. In India, the rates of adherence to imatinib therapy ranges from 75 to 90%. And this is actually a Western data. I think in India, it is going to be a little less also. And
Recording
data has shown
stopped.
that lower adherence rates correlate with worse outcomes. So a study of 87 patients with CML-CP treated with imatinib 400 mg daily has shown that an adherence rate of 90% or less has lower MMR rate of 28%, whereas with adherence rate of more than 90%, the MMR rate are as high as 94%. So before labeling a patient as TKI resistant, we have to check the adherence. So now we have seen the adherence, we have seen the patient is not intolerant, actually looks like TKI resistant. So at the time of this treatment failure, what we have to do is we have to look at the bone marrow examination to allow proper determination of CML phase and documentation of additional chromosomal abnormalities, and we have to look at TKD mutations. So these kinase domain mutations, we have a number of kinase domain mutations. When they should be checked in chronic phase when the milestones are not achieved, there's a loss of response or disease progression, or in newly diagnosed cases of accelerated or blast phase, or the patient has progressed from CML to blast phase or accelerated phase. These are the time these point mutations should be checked. So this is from one of the latest papers in which they have shown that this is a chart in which they have shown the mutated region, the mutant cells, and the drugs which are resistant. The red ones show the drugs which are completely resistant to those mutations, and yellow ones show the intermediate sensitivity, and the green one shows sensitivity to the various mutations which are seen. So depending on this chart and looking at the mutation which is being given in the report, we can decide on our therapy. So, and when we are ordering the test for BCI TKD mutation analysis, we should order NGS-based TKD mutation analysis, because in the recent guidelines, it has been shown that the NGS-based TKD mutation analysis is actually a little more sensitive than the age-old Sanger sequencing, because they are able to pick up some low-level mutations also. So we have seen that what causes resistance. So what are the strategies to overcome these resistance? Earlier it was said that escalate the dose of imatinib is one of the criteria to tackle the resistance if the patient doesn't have any TKD mutation, but this is actually no longer followed these days. We usually switch from imatinib to second generation TKIs. So what they say is the second line treatment with dasatinib, bosutinib, nilotinib can yield higher response rates in patients who have inadequate response to imatinib, including higher rates of MMR, and they are better than imatinib dose escalation. And earlier the switch, the better it is. So when, how, and what to choose. So when we decide a second generation TKI, we have to just look whether the patient is intolerant, as I've told before, whether the patient has some resistance, TKD mutations. Third, again, we have to look at the comorbidities and preferences. That is very important, again, to choose the second generation TKI. When we look at the convenience and compliance, we say that all TKIs are oral, except nilotinib, all are once daily. So this is a chart which shows the switching TKI for toxicity and intolerance, the common side effects of these drugs like rash, fluid retention, edema, weight gain, for which a dose reduction can be done. So like nilotinib, which has rash, headache, increased bilirubin, impaired glycemic control, dyslipidemia, or dasatinib, pleural effusion cytopenias, or GI toxicity with bosutinib, or rash and hypertension with ponatinib, then dose reduction is enough. But if the patient has some prohibitive toxicities, that is an indication that a switch has to be done. So when we look at intolerance and toxicities to a particular TKI, we have to see whether the patient has some tolerable side effects or these toxicities are prohibitive. So the prohibitive toxicities, for like example, are for dasatinib is pulmonary hypertension, for the recurrent pleural effusion for dasatinib, pancreatitis for ponatinib and nilotinib, arteriocclusive events for ponatinib and nilotinib, dementia like Lewy body ALS, Parkinsonism, any TKI, enterocolitis for bosutinib, immune-mediated myocarditis, hepatitis, and nephritis, any TKI. So if any of the prohibitive TKI toxicities are present, we should consider switching on to another TKI. We know that the toxicities of these TKIs are actually non-overlapping, and this figure shows the various toxicities which seen in one figure and not seen with in one TKI, seen with one TKI, not seen with another TKI. But and it has been shown that when we switch TKI for prohibitive toxicity for one particular TKI, the dose of the new TKI does not have to be the dose recommended for resistance. So when we are changing the TKI for resistance, this is the standard dose. But when we are changing the TKI for toxicity, the lower doses are as good if a good MR has already been achieved. So for bosutinib, it is 100 to 200 once a day. Dasatinib, even 20 mg is okay. Nilotinib, 150 BD or 150 to 200 mg OD, or for ponatinib, 15 to 30 mg OD. And why they are saying so is because it has been seen that though these TKIs have actually non-overlapping toxicities, there is something called TKI cross intolerance that is more common than which has been previously thought. When patients have intolerance toxicities to one of the TKI, they may have more often intolerance to other TKIs also. So, for example, it is seen that if the patient has got pleural effusion with dasatinib, may be at risk of developing the same with another TKI also. So, it has been recommended as shown here that if the patient has achieved adequate MR and we are changing the TKI for prohibitive toxicity, then we can consider some lower doses instead of the doses recommended for resistance. So now coming on to just seeing the data, the summary of second generation TKI inhibitors in CML has shown good response. The PFS rates is approximately 56% with dasatinib, 57% with nilotinib, and the overall survival is more or less 70 to 80% with all the three TKIs. That is post imatinib resistance. Now back to our case. So our case was case of CML-CP intermediate risk. We had started on imatinib. On imatinib, after 8 months of therapy, patient had developed pancytopenia. So what to do next? We sent an RQ-PCR. It was 0.8%. Bone marrow aspiration and biopsy was suggestive of hypocellular bone marrow with no increase in blast. Cytogenetics were normal. TKD mutation analysis not detected. So was the case of imatinib-induced myelosuppression with no TKD mutation. This, I think, is a very common thing which we see in our day-to-day practice. So what we did, meanwhile, we could do anything. First, we have to increase the counts. So we started the patient with some darbepoetin, elternambopag, and when the blood requirements were increasing and were not decreasing, we increased the darbepoetin to 120 mg weekly, and danazol was also added. Then gradually, over a period of time, steroids was also added, low dose, only 20 mg we added. And gradually, we tried to introduce imatinib at low dose of 100 mg, but the patient couldn't tolerate that also and was continued on supportive treatment. Meanwhile, we tried to counsel the patient for transplant. The relatives completely denied. They were like, we cannot go for transplant, lots of logistics with the family. Fine. What to do next? We gradually stopped the TKI, continued with the supportive treatment, and waited for the counts to improve a bit. Gradually, over 8 weeks period of time, we saw that the hemoglobin improved without transfusion support, PLC improved, and platelets also improved to 78,000, and patient was still on weekly darbepoetin, elternambopag, and danazol, and low dose steroids. So we looked at the toxicity profile of the various drugs and saw that bosutinib is one of the safest when it comes in terms of cytopenias. So we introduced bosutinib at 100 mg OD and gradually followed the escalation dose, escalation path as I had told before. We increased to 200 mg OD after 15 days and then increased to 300 mg after 4 weeks. But the patient actually couldn't tolerate 300 mg and developed repeated diarrhea, and even after giving supportive medications. So we continued the bosutinib at 200 mg OD. At 3 months post bosutinib, RQ-PCR was 0.3%. Our patient is still continuing bosutinib, has not achieved MMR, but is still continuing in complete cytogenetic response. She is happy, clinicians are happy, everything is fine. So before going to the next scenario, we'll discuss a case 2, which is also, seen in day-to-day practice. What we see is it's a 30-year-old male patient diagnosed with CML-CP in January 2024, was started on imatinib. RQ-PCR at 3 months were 11.3%. Other things were completely fine, so we didn't change the therapy. At 6 months was 7.8%. Still was not an indication to change the therapy. We did not change, but we monitored 3 monthly. At 9 months, it was 3.2%, and at 12 months, it was still 2.4%. Definitely, it is fitting into the resistance criteria, so it is imatinib resistance. We did TKD mutation analysis, it was negative. We started on dasatinib 100 mg, and it was a generic which was started. 3 months post dasatinib, still RQ-PCR was 2.1%. 6 months, it was 2.5%. What to do next? What are the options left to us now? Definitely, what the recommendations say. What they say is, if a patient has developed resistance to a second generation TKI in second or later line therapy, switching to another second generation TKI is actually not indicated unless there is a guiding mutation. Our patient did not have any TKD mutation, so switching on to nilotinib and bosutinib is not going to help. And changing to a third generation TKI is better. And why they are saying is because there are a number of data, they are backing this up, that in a systemic review of patients with CML-CP with resistance or intolerance to previous second generation TKIs, what they have shown is, if we change to another different second TKI only, the complete cytogenetic response rate was 22 to 26%. In contrast, treatment with ponatinib, the complete cytogenetic response rate was approximately 60%. So when we look at ponatinib, we know there's no clear definition for response, but BCR-ABL more than 1% of pH, more than 0% are insufficient for optimal survival. And when patient is having T315I mutation or resistant to 2 or more TKIs, ponatinib is actually which is indicated. FDA had approved it at 45 mg once daily dose, but cardiovascular toxicities are up to 30% in 45 mg dose related, and which actually is a significant toxicity. Hypertension, hyperlipidemia, diabetes, they all should be managed very well. Preliminary data has also suggested that if complete cytotoxic response or MMR is achieved, the daily dose can be decreased to 15 mg daily, followed by careful monitoring of disease and toxicity. And LOHSCT should be considered if appropriate. So, summary of third generation TKI inhibitors and chronic CML and chronic phase post to second TKI failure has shown that if the phase trial has shown a very good MMR rate of 40% and after a follow-up of 57 months and OS of 73% at 5 years. But it has shown that adverse events occurred in 31% of the patients, which were ioto-occlusive adverse events. The most common adverse events occurring in more than 40% of the patients were rash, abdominal pain, thrombocytopenia, headache, dry skin, constipation, severe skin rashes, pancreatitis, and severe hypertension. So next came the trial of OPTIC trial, in which what they did was, upon achievement of BCR-ABL1 less than 1%, the dose of ponatinib was reduced to 15%, and they compared the efficacy. What they saw was overall survival was almost similar with all these three doses of 45 mg or 30 mg or 15 mg when they had followed this particular policy. So the response-based dose reduction strategy in OPTIC resulted in comparable or better efficacy outcomes. Fewer dose reductions related to adverse events and fewer exposure-adjusted treatment-associated arterio-occlusive events, further demonstrating the benefit of the response-based dosing regimen used in OPTIC trial. Then came another third generation drug, that is asciminib, which is a STAMP inhibitor. It is still in the market and it is, at present in hype. Everywhere we are talking about asciminib. It came FDA approved after ASCEMBL trial, which was a trial between asciminib twice daily, 40 mg, and bosutinib 500 mg once daily for patients with adults with CML-CT previously treated with more than 2 TKIs, failure or intolerance to most of the recent TKIs, and in this trial they did not have any T315I mutation. And what they saw was the MMR was significantly better. It was 25.5% compared to 13.2%, and adverse events were lesser compared to bosutinib. Also, it was seen that the incidence of ioto-occlusive adverse events was only 5.1% with asciminib. So when we have ponatinib and asciminib, and we have to choose among the third generation TKI, how to go about this third generation TKI. A simple slide to summarize this. If the patient has primary resistance, failure to achieve a BCR-ABL of less than 10%, progression to advanced phase disease, that means BCR-ABL is more than 10% and progression to advanced phase disease, ponatinib should be favored. However, if there is intolerance to previous TKIs without failure, and BCR-ABL is less than 10%. It's failure to achieve later molecular targets, but BCR-ABL is less than 10%, then asciminib should be favored. For T315I or non-T315I mutations, both the agents have reasonable efficacy. But if the patient has compound mutations or pancytopenia limiting dose intensity, neither agent is with evidence for efficacy. And in real-world settings, when we are choosing this asciminib or ponatinib, we have to look at the pocket of the patients. I've told before, asciminib is costly. Of course, it is not all the patients are going to agree to use a drug which is going to cost them 1 lakh per month. And ponatinib is not available in the country. It is imported and it is very, very costly, even costlier than asciminib, with a lot of adverse events. And the scenarios where asciminib, not ponatinib, is particularly effective is compound kinase domain mutations. The patients who have poor response to first line dasatinib and loss of response after 12 months with compound mutation. In that case, neither asciminib nor ponatinib is going to be effective. The experts are recommending that asciminib plus ponatinib may be effective in this setting. And the second situation where neither of them is going to be effective is TKI resistance in the setting of marked cytopenia. Patients who have failed 2 or more TKIs with extensive interactions cause severe neutropenia and thrombocytopenia. None of these drugs is going to be effective. LOHSCT is the way to go about. So when we choose the TKI inhibitors, sequencing in the setting of resistances, as I have told before, we have to, the second line TKIs should not be rotated among each other. If there is resistance to a second line TKI, directly jump to third generation TKI. Ponatinib and asciminib, if situations are there which both of them are not going to work, go for LOHSCT. And the dose they are recommending is for ponatinib 30 mg per day till PCR is less than 1%, then 15 mg daily. And if they are having T315I mutation, then start with 40 mg per day till PCR is less than 1%, and then reduce to 15 mg daily because of the high toxicity ponatinib is having. For asciminib, they are recommending 80 mg daily or 200 mg BD if T315I mutation is there. Next, when we have asciminib and ponatinib and the situations like both have failed, or other situations also, in looking at the cost issues, we should go for allogeneic stem cell transplant. So what are the situations where allogeneic stem cell transplant is considered in CP1 is disease resistant or intolerant to multiple TKIs, very rare patients with inadequate recovery of normal hematopoiesis, therapeutic option for patients in CML-CP with resistant to second generation TKIs, or who are potentially harboring T315I mutations. So for patients who are resistant to initial second generation TKIs, which is given either as first or second line therapy, the chance of achieving a durable response to alternative second generation TKI is low, as I have told before. So the option is go for ponatinib or asciminib or any other experimental agent. But along with that, a donor search for transplant should be actually started. And so failure to respond to ponatinib after 3 months of treatment, directly go for allogeneic stem cell transplant. AP patient should be treated as high-risk patient, but if the response is not optimal or the patient is progressing to AP during treatment, directly LOHSCT. For patients presenting in or progressing to blast phase, directly LOHSCT. And transplant and frank BP is actually not recommended. Important thing is prior exposure to TKIs does not impact the transplant outcome negatively. Patients who are referred to transplants may have a better outcome if they undergo LOHSCT in a better MR status they have because of lower CML burden. So the CABMTR data, which has shown that the patients, whether match-related or unrelated donors, which are transplanted in CP1, for CP1, this is data for CP1, the response rates are approximately between somewhere around 60%. And what are the conditions where LOHSCT should not be considered post-TKI failure or second generation TKI resistance? This is very important in patients which are older patients, more than 65 to 70 years of age. These patients must, the dogma which we have in our mind that the patients must achieve a complete cytogenetic response be considered for LOHSCT. It's like if the patient is more than 65, 70 years of age, we have to look at the toxicity or the morbidity that HSCT is going to cause the patient, and how much a patient is going to survive achieving that, not achieving complete cytogenetic response also. So it has been shown that the patients, if they do not achieve a complete cytogenetic response also, the 10-year survival rate is approximately 75%. And the patients who are older, at least 65 to 70 years of age, who have not achieved a complete cytogenetic response, LOHSCT as a curative option, I don't think so should be offered to them, because without LOHSCT, they are going to survive at least, we say 10 years, 75% survival is there. But with LOHSCT, the mortality is going to be 30 to 40% in those patients. So these patients actually may remain in a chronic phase on optimal TKI therapy alone, or with addition of other agents to maintain a hematological response with or without cytogenetic response. This is a scenario which is very relevant to us in our real world settings. So back to our case. So our case was actually imatinib resistant followed by dasatinib. So which I told, the patient who had not achieved MMR on dasatinib even after 6 months of dasatinib therapy. So we have told that the option left for him is only a third generation TKI. So the patient is not affording ponatinib nor asciminib. Patient has lot of financial issues. No finances for transplant. Patient was adopted. No first degree relative as was available. This is a real world challenge. Now, what to do in this situation? As we have seen, changing to another second generation TKI just in this case may add to the toxicity and may not be beneficial for this patient. And we discussed, I discussed it with many here and there, what to do with this patient. Then came to the mind, just change the brand of dasatinib. We are using, because of the financial issues, I was using a cheaper brand for dasatinib, generic dasatinib. And when we changed it to one of those brands whose bioavailability has been checked with the Sprycel, we saw that 3 months post-change, RT-PCR reduced to 1.8%. And as the patient is still continuing on dasatinib with this new changed brand, we are like, the patient is still continuing and it's just 9 months post-therapy. So we'll see what to do with the patient. So the other combination therapies which are available at present are combination of dasatinib 50 mg daily with venetoclax. So there are trials going on which have tried to use dasatinib with venetoclax, but what they have shown that the outcome with this combination is almost comparable with the historical outcome with single agent dasatinib with a cumulative 12-month MMR of 79% with both the strategies. Then combination of dasatinib and decitabine and dasatinib in 30 patients with CML in accelerated phase and blast phase has shown an MMR of 33% and median overall survival of 13.8 months. So based on this result, a novel combination of oral decitabine and cedazuridine with low dose decitabine is under evaluation in newly diagnosed CML-CP patients. There are some other trials also in which they have tried to use, even I've not incorporated in this presentation, but they have used ruxolitinib to deepen the MMR. They have compared nilotinib versus nilotinib and interferon alpha to deepen the MR. So all these trials are actually having to achieve, they have achieved better molecular responses, but there has been actually no difference in the survival. And as I started my presentation, the aim of the therapy in such patients is not actually to deepen the MMR, like molecular responses. The aim is survival, because anyhow, the patients who have who have been intolerant or who have some resistance or who have been in TKI failures are not going to be the candidates for treatment-free remissions. So before going on to the last, it's important to discuss treatment-free remission in our scenarios today, because it has become a hype today to stop the PKIs. Now, looking at the real world thing, what are the parameters which are actually required for discontinuing the TKI therapy? So patient should have a lower intermediate so-called score, typical BCR-ABL transcript, should have been in chronic phase. Response to first TKI should be optimal. Duration of all TKIs should be 6 to 8 years. Depth of molecular response should be DMR. Duration of molecular response should have been more than 4 years. Monitoring availability is ideal every 2 months in 1 to 2 years. So this is a tool which I have taken from one of the articles in which they have shown some color codes in which they have categorized it, the patients, the conditions which are orange, the TFR is not recommended because it is hardly achievable. Like transcript type of atypical transcript or MR level at 3 months more than 10% or MR at 6 months more than 1%. And TKI overall treatment duration less than 3 years. Yellow characterizes where intermediate scenarios are there, but the TFR can be achieved. Male gender, disease risk is high, typical transcripts, level of transcript level at MR at 3 was at 3, molecular response at 3 months was 1 to 10%, or level of transcript at 6 months was 0.1 to 1%, or TKI overall duration has been 3 to 5 years for imatinib or 3 to 4 years for second gen TKIs with deep molecular responses for approximately 3 years. And green is the scenarios in which these are best possible scenarios where TFR is highly achievable. Female genders, non-high risk disease, typical transcripts, level of transcript level less than 1% at 3 months and less than 0.1% at 6 months. And this can be actually achieved only with second generation TKIs. And TKI overall treatment duration more than 5 years for imatinib or more than 4 years for second gen TKI, and overall DMR for more than or equivalent to 2 years. But the question arises, how many people can actually successfully discontinue TKI therapies? If not looking at the Western people say that 30, 40, 50% can reach and they can successfully discontinue therapy. But just look at the scenario. Guidelines recommend more than 5 years of imatinib and 3 to 5 years of second generation TKI at least, with response of DMR for at least more than 2 years. Now suppose 45% of the people receiving imatinib might achieve this DMR at 3 years. But they should remain in this DMR for next 2 years also. So it can be estimated that about 45% would become eligible to stop TKI by 5 years of therapy. Now in persons receiving second generation TKI, this can be up to 50%. Combining these data, everything together, around 10 to 25% of the people will only be eligible to stop the TKI therapy. Looking at the previous, which I had seen, the green, the yellow and the green scenarios. And this 10 to 20% can be estimated to be successful in about half of the patients. So actually, only 10% of CML-CT patients are the ones who can achieve TFR. So this is being quoted, or this has been shown by the various studies. So the number of patients which met the discontinue criteria here, all we can say were approximately 47 here, 49 in this study, 30%, 10 to 55%, 31 to 37%. Who actually discontinued were 50% of them only, 10% in this study, 23% in this study, 46% in this study, and actually who achieved TFR were actually between 10 to 25. Only one study has shown 25, the other one has shown 12% to 18%. And we all know in Indian scenario, it is going to be less. So a longer durable DMR may improve the TFR rate significantly. So the CML experts are saying that discontinuing the TK after a sustained DMR of more than 2 years results in a 3-year TFR rate of approximately 40 to 50%, while discontinuation after a DMR of more than 5 years results in a 5-year TFR rate of more than 80%. Then another thing to be kept in mind is a single RT-PCR fluctuation in MR4 range in patients who discontinued therapy did not negatively affect the rate of successful TFR. We should not look at single MR fluctuation. We have MR4 fluctuation. Only loss of MMR is the criteria where we have to change the TKI, we have to restart the TKI. Another thing they have shown that the frequency of molecular monitoring following TKI discontinuation every 4 weeks versus every 6 to 8 weeks after stopping therapy had no impact on the rates of TFR. This is very much relevant to us because our patients, we see not every patient will be affording to spend 4,000 to 6,000 rupees for monitoring of PCR every month. But if we convince them, maybe 6 to 8 weeks, they may be ready to spend that. Then another Destiny trial, which has shown that strategy is considering TKI dose de-escalation for a determined duration. They are de-escalating it gradually over 1 year before TKI discontinuation has reported to be feasible, but more studies are being needed for this. This is what we are also following at present at our center, and the patients are actually doing fine. So to summarize the whole talk as present, the reason for the high rates of reported treatment failures in our clinical settings are the patients on frontline TKI are often changed to other TKIs for indications that are not considered as open today, right? For change from imatinib to second-gen TKI to a different second-gen TKI option when BCR-ABL transcripts are more than 10% in 3 months, or even 0.1 to less than 1% after 1 to 5 years of therapy. The patients are in complete cytogenetic response. They are not the candidates for TFR. Simply, we should not change them. Patients who are continuing in complete cytogenetic response also, that if their BCR-ABL transcripts are less than 10%, even after 2 years of therapy, the 10-year survival rate is approximately up to 75% to 80% in these patients. Change TKI even for BCR-ABL transcripts of less than 0.1% in order just to pursue TFR should not be encouraged. When the patient experienced toxicities on TKI, they were often changed to another, regardless of the nature and severity of toxicity, rather than attempting to lower the dose if the symptoms were reversible or mild or moderate, and when the patients were already in acceptable state of molecular remissions. So these are the few reasons why CML being highly curable, few patients land up in treatment failure, and we really don't know what to do with those patients. So to end the talk, the take-home message from this talk is, while choosing the frontline therapy, if the goal is survival, go for imatinib. If goal is TFR, go for a second-gen TKI. Then we have to consider CML risk, drug cost, toxicity profile with respect to patient comorbidities that further decide the choice. Unnecessary switch of TKI should be avoided where dose reductions can actually suffice. If patients who are not candidates for TFR, who are in complete cytogenetic response, that doesn't need to warrant a change of TKI. Older patients with PCR of 1 to 10% also, they can go ahead with being in complete hematological response only. There's no need of LOHSCT for these patients. If resistance to second generation TKI without a specific TKD mutation, unnecessarily, it should not be switched to another second gen TKI that is going to add to the toxicity. Rather, a third gen TKI should be preferred. And definitely for patients with T315I gatekeeper mutations, third generation TKI has to be preferred. Thank you so much.
Thank you, Dr. Malini. Thank you, Dr. Malini, for the fantastic lecture. You almost covered entire thing of CML, starting from ponatinib to asciminib, when to offer TFR, when not to offer TFR, and what are the current challenges in the clinical practice from the cases you already showed. Thank you.
Thank you,
It was
sir.
a fantastic, lovely lecture. And I now request all our discussants to please put the raise hand sign so that we can start our question answer session. First, we have Dr. Nikhil. Dr. Nikhil, please, your question, please.
Thank you, Dr. Malini. That was an excellent talk. You have comprehensively covered the topic of CML. Am I audible?
Yes, you are.
Yes,
audible.
yes. Thank you so much.
Yeah, that was an excellent talk. You comprehensively covered all aspects of management and there were a lot of clinical business. I have a couple of questions. So the cytopenias that you mentioned with TKI therapy, that is a very frequently occurring problem with young patients. So we had a 19-year-old patient who was intolerant to all TKIs. We had started on imatinib, even at very low doses of imatinib, bosutinib, dasatinib, he was having recurrent cytopenias. And even at 1 year, his BCR-ABL was 18%, but that was partly because of the fact that he could not tolerate any TKI for more than 1 or 2 weeks at a stretch. So how do you manage these patients? And if they are intolerant to even low doses of TKI, would you consider them for a transplant?
Yes, so the ideal situation is when they are intolerant to all the TKIs and they are having cytopenias, the only go ahead for these patients is allogeneic stem cell transplant. Now, looking at the scenarios, looking at our like whether the patient is financially okay to go for transplant or not, then you have to look for the donors available. So everything, if it is fitting, yes, it's the ideal candidate to go for transplant. No other way that patient having cytopenias with all the TKIs, I think, can be managed.
My second question is, many other patients who don't respond to multiple TKIs and some of them cannot afford ponatinib and asciminib, especially for a prolonged duration. So in your practice, do you use interferons for these group of patients?
Yes, so when I was in Tata Memorial Hospital, we were using interferons. Actually, there is a trial also. So there is a recent trial, but Tiger trial, in which they have used nilotinib and interferon, and they have shown, good response of nilotinib and interferon compared to nilotinib. Definitely, there is no survival benefit, but the molecular responses are better. So when we have actually exhausted all the TKIs, in our patients, actually, they cannot afford asciminib and ponatinib, we know. Allotransplant is also costly for most of these patients. So we have to try the permutation and combination from all those trials and go ahead.
Right. So you would prefer adding interferon on top of a TKI or using it as a single agent?
So on topping it with a TKI in such patients.
And my third question is, many of our patients, at least who do not respond as well as expected to a first-line TKI or imatinib, of late we have been doing NGS also for these patients. And quite a few of them have ASXL1 mutations coming up on the NGS testing. So how would that change your management with patients having ASXL1 either at baseline or at later points of testing when they don't respond to a TKI?
So it depends, like if they have a TKI resistance, another mutation is there. Suppose the patient has a TKI resistant mutation, which is resistant to a particular TKI, is sensitive to another, and then NGS you have done, but then we will try to use that TKI. I would not consider at baseline only that ASXL mutation in my mind that okay, this one is the one we have to be change any therapy because of that particular therapy. With just ASXL mutation, I personally won't be changing my treatment just on base of that one NGS mutation. As the experts might differ, that is my thing to go ahead.
Once again, thank you so much for the excellent talk.
Thank you.
Thank you, Dr. Nikhil. Dr. Satish Kumar, your question.
Yeah, thank you, Dr. Malini. That was a comprehensive presentation. Really enjoyed your talk. I agree with you that some of our patients maintain their transcript levels around 1% and they don't progress at all when they don't have any mutations by NGS. I had a patient who I followed the previous recommendations and tried to switch between one second generation from imatinib to second generation, one second generation, the other third second generation. She never progressed and her transcript levels remained same, and I just continued her on the same second generation. It's almost 5 years now she has not progressed. That was a good point of learning. The question I had is, if you have to change from imatinib to a second generation TKI, if they don't have T315I and no susceptible mutations by NGS, what is your drug of choice? Do you prefer bosutinib or do you prefer low dose dasatinib in a young patient with low SOCAL score?
So I prefer low dose dasatinib. For these patients, if there are no comorbidities, definitely to go first is low dose dasatinib, which I am preferring in my clinical practice.
Right. So with low dose dasatinib, you have mentioned that if they have a pleural effusion second time, is it better to switch to a different TKI?
Yes, better to switch to a different TKI.
Because we usually give steroids. There was a patient who had a couple of times, and then at that time we were using a higher dose of dasatinib. This is 3-4 years back. Once I switched to low dose, the pleural effusion recurrence has come down. But that's a good point of learning that if they have second pleural effusion with low dose dasatinib, it's better to switch to a different TKI.
Yes. Yes.
Have you seen in your clinical practice renal toxicity with imatinib, and how do you manage that?
Yes, we have seen a lot. Renal, if the patients who are in 10 years down the line, even on Gleevec, have seen the creatinine going up to 1.5 to even 2.5. If we extensively see the literature, actually there are no recommendations as such. But what we have done is to transiently stop the imatinib, and later on, if the patients have achieved a molecular response, a specific molecular response, they are in MMR, we reduce the dose. From the 400, we gradually come down to 100 mg and maintain them on 100 mg dasatinib. I have seen many patients whose creatinine, old age patients, maintain at around 1.5 with that dose. It doesn't increase. So that is the way, by reducing the dose, that is how we have managed many patients with renal toxicity of imatinib.
Okay, so you have not switched to different TKI. You have just reduced the dose of the same TKI.
Yes.
Right.
Yes.
Thank you, Dr. Malini. Thank you so much.
Thank you.
Thank you, Dr. Satish Kumar. Dr. Gopinathan, your question.
Thanks, Dr. Malini, for an excellent lecture. It was very comprehensive. So, just in conjunction with the previous discussion, proteinuria also sometimes being seen with imatinib. So, do you also encounter the same in your clinical practice with borderline creatinine of 1.4 and proteinuria with imatinib? Come across that in your clinical practice?
Sorry, cannot hear you properly.
The question is basically proteinuria on imatinib. Have you come across in the clinical situation?
So no, I have not seen any proteinuria. We have seen renal toxicities with that. So no, I have not encountered proteinuria on clinical practice on imatinib. Probably no. So I don't have much experience with what to do with that particular case. If a patient gets proteinuria on imatinib.
Amit, if I can just, we had a patient with proteinuria, and it was creatinine was going up, Dr. Gopinathan. So we had to switch from imatinib to low dose dasatinib because his proteinuria was worsening on low dose imatinib. Only on changing the the proteinuria came down, but it didn't reverse completely. So it was biopsy proven, if I'm not wrong, membranous proliferative glomerular nephropathy. We thought it was due to imatinib because the nephrologist didn't have any other cause. So we had to switch imatinib to a different TKI. Sorry for interruption.
Right. Thanks. I have two such experiences. One patient was like very severe. She had only came with Anasarta where we have completely stopped the drug and it reversed after that. Now I have a patient with ongoing imatinib and just 1+2+ proteinuria, but somehow I'm able to manage with dose reduction plus Lazilactone. So just want to have some experience. And the second question, for those patients with ischemic heart disease and the borderline ejection fraction, this is like moderate LV dysfunction, what is your go-to therapy? What is your go-to first-line TKI?
So all the patients with this comorbidity of ischemic heart disease, definitely I would prefer imatinib. See, my go-to therapy is always imatinib, irrespective. Only few scenarios I prefer personally dasatinib or nilotinib as the first go-to therapy. Only which I had mentioned in this presentation. Only the patients who have high-risk disorders or who are prone for we have to take them for TFR. If the patient has any comorbidity, I always prefer imatinib for those patients. It is one of the safest drugs, has been tried, very nicely, have seen Gleevec being continued for 20 years for the patients, and they are doing really well at even 80 years of age. We have one patient who is on pacemaker, and pacemaker is since 10 years, still is able to continue with imatinib around say 400 mg and doing really well. So few patients, like you said, ischemic heart disease, I've seen a heart failure patient also taking imatinib doing very well. So with these scenarios, I will prefer only imatinib, no other drug. Even low dose dasatinib, I will not prefer for such patients.
Last second, current birth. If an adolescent comes to you with CMLCP, would you still go with imatinib, or you directly prefer going a second line considering TFR?
So if the adolescent comes with AP, definitely I'll go for second line TK. I will not go for imatinib. I prefer dasatinib for these patients.
Yeah, chronic phase.
What?
Chronic phase.
So
I cannot hear. So what
adolescents
do you
with
say?
adolescents in chronic phase KML upfront newly diagnosed TKI of choice.
So adolescent, yes, this is a case where we have to prefer TFR. In that case, I told you, the only two situations. One, they have to prefer TFR, there we'll go for second gen TKI. And adolescent in AP, definitely second generation TKI. So only these situations are the ones where we prefer second gen TKI. Otherwise, always a matter.
Thank you, Dr. Gopinathan. Dr. Radhika, your question, please.
Excellent presentation, Dr. Malini. It was really excellent. I enjoyed listening to your presentation. My question is, am I audible?
Yes, you're audible.
Yes.
So we have a 40 years male presented with chronic CML-CP. He was resistant to multiple TKIs, resistant to imatinib, dasatinib, nilotinib, bosutinib, ponatinib. After 3 years, we have been maintaining him on multiple TKIs without achieving any kind of molecular response for almost 3 years. His BCR-ABL never dropped to less than 30%. Now his latest presentation is, he is in hematological response, but BCR-ABL is around 40%. What do you recommend? Do you recommend us to go, explore asciminib, bring down the disease burden, and then take him up for transplant? Or can we take him up for a transplant even at the BCR-ABL transcript level of around 40%?
We can, according to my experience, we can take him up for transplant even at the BCR-ABL level of, 30 to 40%. Asciminib, if we, the trials which have shown is actually works in patients whose BCR-ABL is less than 10%. The data is more towards those patients. If the patient is resistant even to ponatinib, when the BCR-ABL was 30 to 40%, means the female burden is really very high.
Yeah.
And the data which we have shown that the patients who have not achieved complete cytogenetic response, it actually for the patients who maintain the BCR-ABL between 1 to 10%. If the BCR-ABL is more than 10%, anyhow, they are recommending that upfront allogeneic stem cell transplant should be done. And it doesn't matter what is the, the BCR-ABL at the time of transplant. It is 10%, 20, 40, 50%, doesn't matter.
Yeah, perfect. This is what even we had discussed with our senior colleagues and all. My second question is in continuation with the previous question. In an adolescent CML-CP, when you upfront want to consider for dasatinib or any second line agent, what is the preferred dose? Dasatinib 100 or dasatinib 50 mg? Young adolescent CML-CP, newly diagnosed.
So I am now in my clinical practice. We are using dasatinib 50 mg as the upfront dose. We are seeing good toxicity profile and good, good response, and we are monitoring the response at 3 months. We have a couple of patients whom we have seen a very good response at 3 months and 6 months. So I prefer using dasatinib 50 mg with a good brand. Generics should be a very good brand. I will not recommend using any brand.
Yeah.
The one we are using is the one should have. We first check the trials. If there are any trials are there for this generic with the original spices. If they have some studies in the background, then only we are using it.
Perfect. Even in my clinical practice, I have switched over like good number of people into my dasatinib 50 mg doing all well. My third question is, what are the conditions where you upfront consider an IRMA mutation panel? I mean, we generally do it at TKI resistance, right? So what are the conditions where you, because in your presentation, you have presented that in CML, AP, BP, you even consider it upfront, right? IRMA panel. I mean, is that?
No, only in my presentation, it was accelerated phase and last phase upfront we have to consider.
Okay, sure.
In CML-CP, we are not considering. Only the two scenarios we are upfront considering are accelerated phase and last phase. Definitely, we consider it upfront then.
Fine, perfect. My last question, I have a patient who is CML presented in, This lady is a CML in blast crisis, whom we have treated with some kind of ALL. I mean, CML in ALL, lymphoid blast crisis. We treated her with dasatinib plus an ALL-based mild protocol. She got into remission and then she relapsed after 6 months because we couldn't immediately take her up for a transplant. At relapse, she presented with pleural effusion. So a patient who relapsed on dasatinib with pleural effusion, what should be the TK of choice now?
So definitely, I'll say first we have to work up for transplant,
Yeah.
take up and start exploring asciminib, ponatinib for these patients. If the patient has relapsed on dasatinib, I don't think a second generation TKI is going to help this patient.
Yeah.
We have to change a third generation TKI and definitely immediately take up for transplant after giving salvage therapy.
So she is being planned for transplant. She has a 10/10 matched sibling available. But the thing is, she presented at relapse with pleural effusion. So we started her on an ALL-based regimen. We were a little skeptical what should be that attached TK, because obviously dasatinib is not an option here. Nilotinib in a blast crisis, in a blast phase, is not an option.
Not an option.
Asciminib and
No.
they are like beyond our financial limits. So can we consider an imatinib higher dose 600? Is that what we have considered in this case? But is that an appropriate?
So I'll tell you, in our clinical practice, when we have so many CML patients, so sometimes it is not anything is appropriate. Things are not appropriate. It depends on the case-to-case scenarios, cost and finances. We have to explore the options. If we don't have any other option, ponatinib and asciminib patient is not affording. Definitely dasatinib, the patient has pleural effusion. Low dose dasatinib can also not be tried. Nilotinib has not a good role. But still nilotinib can be tried, or imatinib high dose can be tried. Just bring the patient in CP2 somehow and should be in CHR and then take up for transplant.
So we consider
that's where to go ahead.
Yeah. So we took her off with an ALL-based UK ALL-based regimen along with imatinib 600 mg. We got stuck with a prolonged neutropenic fever and all. We got away with it. The counts recovered. We got an MRD done, and MRD is 0.01. MRD is positive, but borderline positive. So
this is the ideal time to take for transplant.
MRD is positive, a borderline positive. So we are just thinking like, should I give one more cycle, get her into proper MRD negativity, or even at a borderline MRD, take her up for a transplant? Is there where we are stuck up, but we are more clinking towards taking up for a transplant at MRD 0.01.
Yes, I will also suggest take up for MRD of 0.01% only. Sure. Directly take for transplant. Now it's.
Yeah. Thank you, Dr. Malini. That was excellent. Thank you. Thanks.
Thank you. Thank you.
Thank you, Dr. Radhika. From the same note, could we have tried bosutinib in that case, what Dr. Radhika described?
The bosutinib could have been tried in this case, sir. Like again, when the second generation 1 TKI is resistant, the guidelines, they do not recommend second generation TKI. Now it depends on us what we are trying. We can try nilotinib, bosutinib, or imatinib high dose. It just depends on the, I think, physician's discretion to decide now.
I explored the option of bosutinib also in the literature. Bosutinib also causes pleural effusion. So that's when I had to revert to nimatinib here.
So there's the concept of that cross intolerance. If they are like what we had shown, that if this TKI like intolerant to one pleural effusion being caused to dasatinib, then the probability of pleural effusion by bosutinib, or for that sake even nilotinib, is going to be higher in this patient.
Sure. Why is nilotinib contraindicated in a blast crisis? I mean, what's the logic behind that? And why
it's not contraindicated basically. So we prefer dasatinib because they say that it crosses like for even the CNS, like for CNS disease also dasatinib is very good. So it is actually not contraindicated. People use it.
Sure. Thank you.
Thank you, Dr. Radhika. Dr. Akanksha, your question, please.
Yeah, hi, Dr. Malini. Thank you for the very comprehensive talk. So I just have one question regarding ponatinib. So we have some, ponatinib preparations, which are the Bangladeshi version. So do you have any experience of using those? And apparently it's called as Ponaxin, and it's apparently 15 mg tablet costs around 20,000. So just wanted to know if you have any experience of using that particular brand. And second question was that you mentioned about the dasatinib particular generic, which in your patient you did not achieve a adequate molecular response. So, which brand are you using now for dasatinib? And regarding the Ponaxin, your experience for the same?
So I don't have any experience with Ponaxin. I have the experience with original ponatinib, and we were in extract. We were using it for a couple of patients. Toxicity was really very high, really, really very, very high after ponatinib. With even 15 mg, we saw a lot of toxicity. I've used in 4 or 5 patients with original brand. I have really no experience with the Bangladesh brand of ponatinib. So after that, we have burnt our fingers with ponatinib. I'm really scared to use this drug after we have seen the toxicity profile. And what generic you are talking about is presently I'm using the Dasanag for the patient.
Okay. So basically,
Natco.
I would just like
I'm not
to share
here to
that.
promote that.
Yeah,
I'm not
yeah,
here to promote it, but there were 2-3 generics. If you see that there are a lot of dasatinib generics which has come in the market. So I switched on to Natco one.
The Natco one, and that was
Doing
50
good.
mg, right? Yeah.
Yes, it's doing good.
And any experience of managing, CML cases? A lot of females, they, especially in a government setup, sometimes we have patients already on imatinib and the female patients become pregnant. So any experience of managing such cases?
Yes, so
Patients of
what we have
CML
done is, yes, you definitely stop the TKI as soon as we get to know the patient is pregnant, tell them to, go for NPP if possible. And if suppose they are not ready and they are very adamant, no, we want to continue with the pregnancy. So what we have done in the clinical practice is at 3rd trimester, we should avoid using any of the TKIs as much as possible and try to maintain that the patient stays in CHR. If the patient is losing CHR also, in 3rd trimester, we have introduced imatinib for these patients. And we have not seen any toxicity for those patients. And we have also avoided them, asked them not to go for lactation and breastfeeding. So that is how we have managed.
Okay. Thank you so much.
Dr. Akansha, sorry to interrupt. So the question you were asking regarding the ponatinib from a Bangladesh brand.
Yes.
Actually, we have burnt our fingers very badly in a couple of patients where patients were already on ponatinib and there was an availability issue and the brand from Bangladesh was available. Couple of those patients developed very bad skin reactions and we had to discontinue the drug. So our experience with the brand from Bangladesh has not been great.
So this was used as a failure in a case of TKI failure or upfront?
This was used in a T315I mutated PH positive ALL. And having said, we have quite a few patients of PH positive ALL who responded very well to ponatinib and the toxicity profile was also manageable. We also have 2-3 patients of chronic phase CML who have been tolerating ponatinib reasonably well, but we don't go up to the 45 milligram and we usually start with the 30 milligram.
And in the PH positive ALL, have you been able to, reduce the dose to 15 mg in any of these patients? Because the higher doses, if you're giving it with chemotherapy, then it becomes very toxic.
So as much as possible, after 1 or 2 cycles, we try to take them up for transplant. We do not wait till they are molecular MRD negative. But if they're MRD negative by flow and the disease control has been good, we try to take them up for transplant at the first possible opportunity.
Okay. Thanks a lot.
So the ponatinib you are using is the original one only now.
Yes.
Not the Bangladesh brand, right?
It's the original one, Dr. So Bangladesh brand we have tried, but our experience has not been good in a couple of patients, and after that we have discontinued using it.
Thank you.
And on that same note, we also had a couple of patients who actually progressed on ponatinib. The same scenario that you described, PH positive ALL, T315I mutated on ponatinib. While waiting for a transplant, the disease relapsed on ponatinib. And we have 2 to 3 patients who responded to asciminib in this scenario, 200 milligram twice daily with asciminib, and we were able to use asciminib as a bridge to transplant in these patients who are refractory to ponatinib. We have written up these cases and it's under peer review for publication. But asciminib, though it is not licensed for this indication, can also be an option in patients who are ponatinib refractory or intolerant.
Sure.
Thank you. Dr. Nikhil, from the same note, when you used ponatinib in PH positive ALL, what was the combination chemotherapy used? You're muted.
So we are used it with hyper-CVAD.
So one more question. So what were the type of adverse events you saw? So did you see any, autoocclusive adverse events for these patients? Because when you have taken ponatinib patients for transplant, was the toxicity more in these patients or less? Because what I have experienced is the patients who have experienced, taken ponatinib before and when we take up them for transplant, somehow the toxicities are really very high for those patients. So I just want to know your experience in this when we have used so much of ponatinib.
So we have had a couple of patients with vaso-occlusive events, but they were of mild intensity. But mostly the cytopenias and related toxicities have been quite severe. And like you rightly mentioned, when we take up these patients for transplant, in the peri-transplant period also, the complications like severe cytopenias and other things have been relatively more. And we have also had few patients for whom post-transplant, they had poor graft function for quite some time.
Yes. So, after ponatinib, this happens.
Absolutely. Absolutely.
Thank you, Dr. Nikhil. Dr. Rajni Priya, your question, please.
Thank you, Malini ma'am. That was an excellent talk. So majority of my questions were answered in your talk and from the previous discussion questions. So just wanted, it's clear from your talk that you're comfortable using with the low dose dasatinib in almost all your newly diagnosed patients. So what about the patients in imatinib resistant cases? Like what is the dose you want to start dasatinib in those patients? You want to start with 140 mg or what is the dose you start in those patients?
So in imatinib resistant patients, I'm starting with 100 mg of dasatinib and seeing the tolerability. If the patients are tolerating, okay, fine. If they are not tolerating it, and if the molecular response has been achieved, then we are coming down to 50 mg. Otherwise, for imatinib resistance, we are starting at 100 mg.
100 mg, yes.
Yeah.
So what is like for dasatinib induced thrombocytopenias, like is there any cutoff platelet value, like you're comfortable, you want to stop the TK, or after a particular cutoff you want to start the TK again? So is it like any cutoff value for the thrombocytopenias?
If we see at the literature, there is actually no cutoff values. That depends on our day-to-day practice and what we are comfortable using it. For imatinib, I have seen for most of the patients, they can do fine at even 40 to 50,000 of the platelet count. Same for dasatinib, 50 mg in my experience, I have used it for 40 to 50,000 platelet count and they are doing fine. No need to stop it. So even one patient used to maintain a platelet count of 30,000 and have been using it in Tata Memorial, and later we had taken that for transplant. But during the peri-transplant period, to maintain the molecular response, dasatinib 50 mg we had continued at a platelet count of 30,000 also, doing fine. But if we look at the clinical scenario, usually what I do is, if the platelet count becomes less than 50,000, that is the time I consider stopping the TKI and re-challenging it once it again reaches 75,000.
Okay. So can we just continue with the thrombopoietin receptor agonist and
so
continue with the TKI?
We have done that also. We have used that also in a couple of patients. Because see, romiplostin is approved for chemotherapy-induced thrombocytopenia, and off-label we are using eltrombopag also. So have been using romiplostin in few patients and continuing with the TK to maintain a platelet count around 50,000 or something, and have been using eltrombopag also, continuing it and using continue to use a good number or a good dose of TK therapy. We are using it.
Thank you, ma'am. So like recently I had one patient, CML-CP patient on imatinib for more than 5 years in good molecular remission. So she presented with sudden loss of vision in one eye. So have you seen, we have done, the ophthalmologist has evaluated for CR, AVO and VIVO and it is negative. So they were attributing it to the drug. So have you seen any patients with any TK presenting with visual losses, not having any thrombotic cause?
So your patient was in imatinib?
Yes,
right. So I have not seen, like we have to rule out, immune causes now. I have not seen any patient on imatinib progressing to optic neuropathy, like having optic neuropathy. I have seen patients on accelerated phase when we put them on, dasatinib, and later on when they progress to blast phase, we put them on ALL-like therapy. In that case, we have seen probably that was because of some other chemotherapies and not dasatinib. And I would suggest immune causes should be ruled out, discuss with ophthal, try using some steroids, and more literature search will be needed for it. I really don't have any personal experience of optic blindness in a case of TKI therapy,
Okay.
attributing
Thank
only
you.
to TKI.
Okay. Thank you, ma'am. Thanks a lot.
Thank you, Dr. Rajni Priya. There are some questions from the audience. A question from Dr. Negasa. Is TKI-induced pleural effusion to be considered as TKI intolerance?
Yes, yes, dasatinib-induced pleural effusion has to be considered as TKI intolerance. The way to go ahead is to stop the dasatinib, wait for it to resolve, can start with slow dose steroids, and then reintroduce dasatinib at a lower dose. If the patient, again gets a second time pleural effusion, that is the time to change the TKI therapy.
Thank you. Another question from Dr. Negasa. Have you seen any patient with TKI-induced vitiligo?
No, I have not seen any patient with TKI-induced vitiligo, but again, I'm saying immune phenomena after TKIs are very high. So if the patient can get immune phenomena of one category, vitiligo is also kind of immune phenomena that can also, we don't know about. I really don't know. And I don't think so, patient having vitiligo after TKI, that should be the reasons to, stop the TKI. It's just a cosmetic thing. It's not going to take the life of the patient.
Thank you. Another question from Dr. Tanveen Rahman. 36 years male, newly diagnosed CML-CP, started on imatinib 400 milligram for 5 weeks. After 5 weeks, patient developed severe cytopenia for which imatinib was stopped. And after spontaneous resolution of cytopenia, again imatinib was started at the same dose of 400 mg. After getting a total of 8 weeks of imatinib, the peripheral blood film was showing leukoerythroblastic blood picture. What do you do now?
It's just 8 weeks of therapy. So while CP, firstly, if the patient has cytopenia, severe cytopenia, for which first we have to see what was the dose interruption. So the dose interruption for my clinical practice, I'll see what was the dose interruption. Dose interruption was more than 1 week or more than 1 week. If it was less than 1 week, I usually reintroduce at the same dose. If it is more than 1 week, up to 15 days or more than that, we try to reduce the dose of imatinib and reintroduce. So in this scenario, it has been reintroduced at the same dose. At 8 weeks, there's just leukoerythroblastic blood picture, no other complaints. If the cytopenias are going ahead, if the things are going fine and cytopenias have actually resolved, then we should continue it at the same dose. The leukoerythroblastic blood picture can be an indication of marrow recovery also. We should know why leukoerythroblastic blood picture is there, whether it is progressing, cytopenias are progressing, or the counts have recovered. If the counts are recovered, okay, continue at the same dose. If the counts are going down, it is not recovering, again cytopenias are there, and even at low dose of imatinib, cytopenias are there, we should go ahead and do a bone marrow to see what is happening with the marrow.
Absolutely. Another question from Dr. Krishna Ratnam Kannan. Does every newly diagnosed patient of CML needs a bone marrow biopsy? Or you can just avoid bone marrow biopsy for every patient?
So according to my experience, every newly diagnosed CML patient needs a bone marrow biopsy because we have to look at the degree of fibrosis. That is going to tell about, fibrosis tell about the prognosis of the patient and also the blast enumeration. Sometimes in aspirate, we miss the number of blasts. The sheet of blasts can be seen in biopsy. The discordance can be there. So I recommend biopsy for all the patients.
Exactly. Another question from Dr. Kannan. For patients on dasatinib, how frequently do you monitor for pulmonary hypertension? And what is the cutoff of pulmonary artery hypertension?
So we are usually not monitoring these patients as such for pulmonary arterial hypertension. As such, if the patients if they get some symptoms, these are the only time we are sending them to a cardiologist to monitor pulmonary hypertension. In routine practices, we are not monitoring pulmonary hypertension unless and until patient gets some symptoms pertaining to cardiovascular disease. We just look at the symptomatology of the patient and then monitor them. Routinely, we are not doing it.
And any cutoff do you measure for pH?
The 25, I think I really don't know about it.
And if the patient develops pH, do you change to other second line therapy or do go for the line?
Yes, pH, pulmonary arterial hypertension, is one of the prohibitive toxicities for dasatinib. If the patient develops it, we have there's no role of low dose dasatinib also in such a patient. We have to change the pH.
And that you will change to another second line.
So ideally, if it's because of the prohibitive toxicity, so we should change to a second line. It is not because of resistance. So we should change to a second line at a lower dose.
True. Another question from Dr. Nilesh Shah. Is it usual practice to do a screen of additional cytogenetic abnormality and always to check for the BCR-ABL mRNA transcript prior to starting any TKI therapy?
Yes, that is a mandatory. We should look for cytogenetics for all the patients because additional chromosomal abnormalities is an indication of high-risk disease, and to you start second generation TKI upfront also. And yes, we have to look at the transcript type because that is going to help us in monitoring. Suppose a patient has an atypical transcript which is not being picked up. So the monitoring is going to be two different ways. So we have to do a transcript at this.
Perfect.
These two are mandatory.
Absolutely. Another question from Dr. Rajkumar Ramaswamy. Any role of combination of TKI with interferon to achieve TFR after the patient achieves MR4 or MR4.5 for 2 years based on Destiny trial?
No, I will not suggest to just add an interferon just to achieve a TFR if the patient has already achieved a DMR. No, just continue it for more time, and we have to avoid toxicities for the patient. Why to just add one more, drug for this patient just to achieve TFR and already when the patient has achieved a deep molecular response? Personally, I will not recommend adding any more.
Exactly. Another question from Dr. Usha Singh. What is a safe TKI do you use during pregnancy?
So, pregnancy in third trimester, imatinib is the only one with that.
And if the patient of CML develops carcinoma breast with ER positive, PR positive, does tamoxifen or letrozole is safe to combine with imatinib?
So we have to, imatinib has to be continued. We have to check the drug interactions. If there is any role of any, reducing the dose or not, I really don't know about it. We have to check the drug interactions. What is the role of that? And accordingly, modify the dose. Accordingly, we have seen many patients with dual malignancies, GI carcinomas, have seen breast malignancies, and have seen a colon carcinoma also with CML, have continued imatinib with them along with their chemotherapy. During the time of chemotherapy, we usually check the interactions, look which of the drugs are interacting with each other and which of the drugs need a dose reduction. We do that and we continue. We just have to check it once.
Thank you. And another question from Dr. Priyanka. Can you throw again some highlight regarding how do you define primary TKI resistance, imatinib resistance, and secondary imatinib resistance? And is it advisable to change TKI if the patient has got primary imatinib resistance?
So basic primary imatinib resistance just is at 1 year if the PCR-ABL transcript is more than 1%, they define, okay, the patient is actually resistant. Yes, if the patient is resistant, we have to look for TKD mutation, and accordingly, we have to decide our next line of therapy. This is first thing. Second is secondary resistance is relapse, or we call it loss of response. Anytime there is loss of MMR or the loss of basically not MMR, MR2 also, that defines secondary resistance. One log change in that molecular response status defines a secondary resistance for the patient. And a patient who has, as I told before, primary resistant, we should consider changing our TKI therapy depending upon the TKD mutation analysis. If the patient is already on a second generation TKI, if patient is on imatinib, should go for second generation TKI depending on TKD mutation analysis. If the patient is on second generation TKI, if there is no TKD mutation analysis, patient should go for third generation TKI. Should not, hobble around second generation TKIs only if the TKD mutation analysis is negative.
Thank you. Another question from Dr. Raghavendra Rajesh Varkar. If the patient develops pregnancy on imatinib, in what circumstances would you like to immediately terminate the pregnancy?
In all the circumstances, immediately terminate the pregnancy. In all the circumstances. So if the patient, yes, but we should see the guidelines, whether it is coming under that category of MTP guidelines or not. Now the recommendations are up to 28 weeks also. At least up to 24 weeks also, they are terminating the pregnancy. Earlier it was only 20 weeks, they have extended the guideline. In all probabilities, it should be done. Because the patient has already received imatinib in the first trimester for that duration at least.
True. And last question is a little bit business-oriented question by Dr. Suresh Sanchite. Is it possible for us to now think in 2024 and convince all the diagnostic labs about BCR-ABL to go about BCR-ABL monitoring at lower rates from the companies so that better BCR monitoring is possible nowadays?
So for that, I will tell, okay, it is possible. Few of the labs are doing it for, I tell you, 2,000 rupees also. But they are using only a single test. Ideally, the test should be done in triplicate. Triplicate is the ideal recommended test to get the adequate molecular response. The labs which are doing it for 1,500 and 2,000 rupees, they are doing it. If we talk to the pathologists, they are doing it on a single run basis. The labs which are actually good labs, which are doing it for more cost, they are doing it triplicate basis. The difference between them is the recheck of the mutation, the sensitivity, how much accurate it is. It is very important to us. We are reducing the cost to bring it to a single time test, but it is we are not sure whether it is right or not. At least a duplicate is needed. We need to be very sure of the ratio. The duplicate at least should be there. So we can talk to the lab how much a duplicate test is going to cost. If they are able to do the duplicate in that amount, so that is okay. But how much, we should talk to them.
Exactly. Well, so I finished all the questions from the audience. Any discussions want to ask? Any other question? Well, so I think there are no more raising signs, and finished all the questions from audience. Well, thank you so much, Dr. Malini Garg, for the fantastic and excellent talk. Lovely talk. What a wonderful discussion. And thank you once again for accepting our invitation as our guest speaker for the day. And I also thank Dr. Anshul Gupta for accepting our invitation as our chief guest for the day. Well, thank you so much, Dr. Malini, once again for a fantastic, lovely, wonderful lecture and a wonderful discussion.
Thank you, sir. We have learned a lot from this discussion. We have also learned it was a kind of two-way discussion, a very junior to answer many questions, but have learned from seniors also. Thank you so much.
Thanks a lot. And I thank all our discussants as well as audience to participate in this webinar, and meet you next week, next Saturday, Sunday with another beautiful webinars. Goodbye for now. Have a wonderful day.
Thank you. Bye-bye.